Good morning, everyone. My name is Qi Yang. I'm from Beijing, China. The topic today is MR imaging of coronary arteries, past history and future prospects. Coronary MRA has several important advantages, including no radiation, feasibility of non-contrast MRA, and also the high temporal resolution together with insusceptible to coronary calcification. Coronary MRA has a history of over 20 years. In early 90s, coronary MRA was acquired with 2D gradient echo approach. Today, image quality and diagnostic performance of coronary MRA are improved. Professor Matthias Stuber's group has been working on this field for many years. Here's the initial image of non-contrast whole-heart coronary MRA at 3T. Both LAD and RCA can be well delineated without any contrast agent. There are several important clinical studies using coronary MRA both at 1.5T and 3T. Here's the 1.5T clinical study led by Dr. Sakuma from Japan. They used three-dimensional coronary MRA, covered the entire heart in more than 100 patients. In their study, they proved that whole-heart coronary MRA allows for non-invasive detection of significant narrowing in the segments with a diameter of more than 2 mm, with moderate sensitivity and high specificity. In order to improve the robustness of this technique, Dr. Sakuma's group also reported the study, the comparison between UK and Japanese patients, and using an abdominal belt, they can further improve the scan efficiency and also reduce the imaging time. Led by Professor Debiao Li from Cedars-Sinai Medical Center, they performed another clinical trial using contrast-enhanced 3T whole-heart coronary MRA technique. This technique can provide very high-resolution clinical images of the coronary arteries, and this bifurcation stenosis can be clearly delineated compared with the invasive DSA. The diagnostic performance of 3T whole-heart coronary MRA is comparable with 64-slice CT angiography. On per patient level, the sensitivity is 94.1%. On per vessel level, the sensitivity is around 92.9%. We continue to improve the image quality of this whole-heart coronary MRA technique at 3T using a 32-channel cardiac coils. This is an example from a patient with normal coronary arteries. This coronary MRA technique clearly rule out CAD with the imaging time less than 5 minutes. Another example shows clearly the advantage of MR angiography over CT angiography. MIP image in a 53-year-old man shows severe calcification at proximal RCA and LAD, overlapping with the coronary lumen. Reformatted MRA shows normal lumen at the site of the calcification on MRI, which are consistent with the findings on X-ray angiography. Another research group from China, they are using the same technique compared with dual source CT angiography. They prove that CMRA and dual source coronary angiography have similar diagnostic accuracies. Dr. Sakuma's research group also proved the prognostic value of coronary MRA. Whole-heart CMRA is useful for predicting future cardiac events in patients with suspected CAD. Also, The absence of significant stenosis on whole-heart coronary MRA is associated very low risk of cardiac event. Same group also performed comprehensive CMR on patients with suspected CAD. In this example, with chest pain, stress-induced ischemia is observed in the anterior septal wall. Coronary MRA revealed stenosis in the proximal LAD, corresponding to the ischemia in the LAD territory. Let's switch to MR vessel wall imaging. In most of patients with acute coronary syndrome, luminal stenosis is less than 50%. The rupture of vulnerable plaque is the cause of cardiovascular events. MR is the only way to image vessel wall and plaque vulnerability. Here's the example of coronary MRA and vessel wall imaging. Using local inversion recovery technique, the blood signal in the coronary artery lumen has been fully suppressed, and you can measure the thickness of the coronary artery wall. In the MESA study, Professor David also used vessel wall imaging to detect artery remodeling. They proved that vessel wall MR detected positive artery remodeling in asymptomatic men and women with subclinical atherosclerosis. The typical high-intensity plaque stands for intraplaque hemorrhage. With positive remodeling, remarkably low computed tomographic density, and high incidence of slow flow phenomenon. Non-contrast T1 weighting in cardiac MRI may be useful for the assessment of coronary plaque characterization in patients with artery disease. This high-intensity signal in plaques detected by non-contrast T1 MRI has the potential to identify vulnerable coronary lesions. The major findings from Japanese group is that the presence of plaque with PMR over than 1.4 visualized by this non-contrast T1 technique is a significant and independent predictor of future cardiac. Intraluminal thrombus can also be detected with MR vessel wall imaging due to the lower T1 value. In this patient, the thrombus has been validated by PAS and correlated with coronary angiography. See, the Sinus research group also invented another technique named catch. They combined black blood and bright blood together to catch the high intensity plaque in the coronary lumen. Here comes the conclusion. Coronary MRA made excellent additions to coronary CTA, especially in patients with severe calcification. Coronary MRA was an important part of comprehensive cardiac MRI. MR is the only way to image vessel wall and plaque vulnerability non-invasively. Thank you.